Our third session is on the topic Osteoporosis in the Elderly, Risk Stratification and Prevention Strategies. The chairpersons are Dr. Anita Nambiar, Consultant Physician and Diabetologist, Lakeshore Hospital, Kochi, and Dr. Ajit Kumar S., Professor of Medicine, SUT, Thiruvananthapuram. We hereby invite the esteemed chairpersons to be on stage to moderate the session. Let us now warmly welcome our speaker, Dr. Ashwin Valliyot, Consultant Endocrinologist, Indian Institute of Diabetes, Trivandrum. Over to the chairpersons.
Good morning to all. Thank you, GSI Kerala State Branch for this opportunity. So the next speaker is Ashwin Valliyot, who is working at present in Institute of Diabetes, Trivandrum. He had many laurels to his degree, and he was the first rank. He secured the first rank in All India NEET examination for endocrinology, and he is son of our Balakrishna Valliyot sir. Thank you. Over to you. I think chairperson should not waste time on introducing the subject. Over to you.
Thank you, Anita Madam and Ajit sir, for the kind introduction. It's indeed a privilege and pleasure for me to present in front of such an esteemed academic audience, including my teachers, and I thank the organizers for this wonderful opportunity. So my task here today is to give you an awareness on the topic osteoporosis in elderly, the risk stratification and prevention strategies. Now, first of all, why this topic? So you must have seen a lot of elderly women in our locality with this appearance. And even as doctors, we think that this is a part of normal aging. But unfortunately, these are all silent vertebral fractures, missed osteoporosis. A golden opportunity to treat was probably missed in these patients. And if properly treated, she would have been more upright and independent. Now, this is the WHO definition for osteoporosis, which means that there is a low bone mass and a microarchitectural deterioration leading to increased bone fragility and susceptibility to fracture. This basically means that you have a very, very brittle bone which is about to break even for a trivial trauma. Now, coming to the pathogenesis of osteoporosis, which is a complex phenomenon, but basically it's an imbalance in the bone remodeling. Now, as you know, you have the osteoblast, which mediates the bone formation, and the osteoclast, which mediates the bone resorption. So whenever there is an accelerated bone resorption and an attenuated bone formation, that means the osteoclastic activity supersedes the activity of the osteoblast, you have osteoporosis. It could be due to multiple factors. It could be genetic, it could be environmental, or it could be due to the disturbance in the hormonal milieu in the body. But all this will contribute to the complex pathogenesis of osteoporosis. Now, the burden of osteoporosis is actually huge, which is more than what you think, because 30% of the postmenopausal women in the world are affected by osteoporosis, and in India, the data suggests even up to 50 to 60%. The most shocking fact here is that 20% of this elderly population is going to die within 1 year of their hip fracture. Now, you need to be very clear of this term fragility fracture. Suppose a 65-year-old female is falling from a 2-storied building and she is suffering from a vertebral fracture. Is it exactly a fragility fracture? No, because a 25-year-old healthy male who is also falling from that same height would also have suffered from that fracture. So fragility fracture means a fracture that occurs from a low energy trauma, such as falling from standing height or less. That means a slip and fall in the bathroom and patient is having a vertebral fracture. That is a fragility fracture. And it is that fragility fracture that is a sign of underlying osteoporosis. And the importance here is that if you are having a fragility fracture, there is a high risk of second fragility fracture in the next 2 years. And this most commonly occurs at vital areas like your hip, spine, and the forearm. Now, when you're having a fragility fracture or you're suspecting osteoporosis, how do we proceed about? The first and foremost always is a proper history and clinical examination. You need to assess whether the patient needs bone mineral density assessment. Always evaluate for a secondary cause before jumping into any treatment. Sometimes you need to go beyond DEXA scan, and finally you have to take a call on whether to treat this patient or not. Now, the issue with osteoporosis in clinical practice is that it's most often asymptomatic. Now, people don't come to you and tell, I have osteoporosis. So you have to elicit soft clinical signs like kyphosis. Sometimes the patient may be telling you that I have lost my height over the years. A retrospective height loss of more than 4 centimeters is clinically significant, and definitely you have to evaluate the patient. And obviously, if the patient is having vertebral fractures, then the patient will present with pain. Now, when the patient is having fractures, this point should be focused in history. Was there a prior fracture? If there is a prior fracture, it's a high risk that the patient will develop another fracture. The age of menopause in a female is also important. Suppose the patient is having premature menopause or a situation like premature ovarian insufficiency, they are more prone to develop fractures. Take a detailed history regarding the calcium and protein intake. Any chronic systemic disease, be it diabetes, CKD, rheumatoid arthritis, all this can again contribute to osteoporosis. Now medications, steroids and anticonvulsants, as you know, are notorious to cause fractures. Pioglitazone in the diabetic elderly population can be a culprit. Even if the patient is taking this pantoprazole for many years for X or Y reason, it can also contribute to osteoporosis in the long run. Now, how do we risk stratify this patient? The first is whether there is a history of fracture or not. Second is the bone mineral density assessment using DEXA scan. Then you have a very simple tool called as a fracture risk assessment tool, which I will be coming to. Now, this is how a DEXA machine is. In DEXA machine, we are measuring the bone mineral density of the person at 3 sites. That is the lumbar spine, the hip, and the forearm. Now, not all patients who comes to your OPD needs a DEXA scan. These are the specific indications for DEXA scan. Women more than 60 years and men more than 70 years, you can go for DEXA scan. And between the age group of 50 to 69 years, if there is a clinical risk factor, like the patient is on chronic glucocorticoids or there is diabetes, you can again go for DEXA scan. Now, as you know, everything comes little earlier in India, be it diabetes, be it cardiovascular disease. Similarly, osteoporosis also comes little earlier in the India compared to Western cohorts. So in the Indian population, you can go for a DEXA scan more than 60 years in women and more than 65 years in men. So any patient with bone fragility fractures at any age, again, you can go for DEXA scan. Now, when you send patients for DEXA scan, keep these things in mind. Calcium supplementation should be avoided on the day of DEXA scan because the presence of calcium in the bowel can falsely increase the bone mineral density. Now, it's not a hard and fast rule, but if the patient has received any radio contrast in the last 2 weeks, then it's better to postpone the scan for at least 2 weeks. If the patient had a previous fracture, then the fracture site should be excluded from the DEXA scan because the presence of fracture can falsely increase the bone mineral density. Now, this is how the patient will bring back the DEXA report. In the DEXA report, you will have the site, the bone mineral density, the T-score, and the Z-score. Now, there is always a confusion which score to calculate. That is the T-score or the Z-score. For that, you should know the concept of T-score. Now, T-score means that the patient's bone mineral density will be compared to a young patient's bone mineral density. That means an elderly patient's bone mineral density will be compared to a young patient's bone mineral density who has attained the peak bone mass. And we are seeing how far is that bone mineral density from the young patient's bone mineral density, and we measure it by the standard deviation score. So in a postmenopausal woman and men more than 50 years, it is the T-score that is to be used. And in younger age, you can use the Z-score. Now, if the T-score comes between -1 to -2.5, it is called as osteopenia. And if the T-score is less than -2.5, then you call it as osteoporosis. Now, you must be wondering why this cutoff of 2.5 was kept. This is actually based on a study by Canis et al. In 1994, which has shown that this cutoff approximately identifies 30% of the postmenopausal women as having osteoporosis. To simplify this, this means that if your T-score comes down by -1, then the risk of your fracture increases twofold. So sometimes in clinical practice, we see that the patient will be having multiple fractures, but when you do a DEXA scan, it turns out to be normal. This is where the limitation of DEXA scan is. The DEXA measures the bone quantity, but not the quality of the bone. The quality of the bone is determined by the microarchitecture, which is indeed determined by the trabecular connectivity and network, which you are not able to measure in a DEXA scan. If you want to know the microarchitecture of the bone, you have a tool called as the trabecular bone score, which is nothing much but a software that is integrated into the DEXA scan. So by measuring the trabecular bone score, you'll have a rough idea of the microarchitecture of the bone. So if the TVS is more than 1.3, that means it is a normal bone, and if it is less than 1.2, that means it is a degraded bone. Now you have a wide variety of options like the QCT, the HRP-QCT. I'm not going much details into this, but just keep in mind that a lot of advancements are occurring all over the world in the field of imaging for osteoporosis. Now, if you're at a center where you do not have DEXA scan, how do we do it? This is a very simple tool which you can calculate from your OPD. Just Google in FRAX score. You will get into this site, FRAX India site, and you have to enter all these details: age, sex, height, weight, previous fractures. After entering all these details, you will have a hip fracture percentage and a major osteoporotic fracture percentage. Now, if it is exceeding more than 3.5% and 20%, then again you can consider treatment for these patients. Now coming to the most important area, the evaluation for osteoporosis. This is where the clinician in us should stay alert. Just to highlight a recent case, this was a 68-year-old female who had a neck of femur fracture, underwent surgical fixation recently. Again, 1 month later, she was readmitted with a vertebral fracture. The treating orthopedician felt something was not right with this patient. An endocrinology opinion was sought. On probing, there was a history of renal calculi 2 years back. The first thing we wanted to see is her calcium value, which came out to be 12.8 with a low phosphorus, a sky-high PTH value, and the X-rays were all suggestive of bone resorption, acral osteolysis. So this was primary hyperparathyroidism, and the imaging USG, MIBI, and 4D-CT all localized to left inferior parathyroidadenoma. Patient underwent parathyroidectomy, calcium normalized, no further fractures. The patient is happy. This is not a complex case or anything, but I just want to highlight that not all patients in the postmenopausal age group has to be labeled as a case of postmenopausal osteoporosis. You have to always evaluate for all possible secondary causes before jumping into treatment and making conclusion. So these are the mandatory set of investigations recommended by the ISBMR before starting treatment. This looks a little bit crowded. I'll simplify this for you. At least do a calcium profile in a patient who is presenting with fracture or you are suspecting osteoporosis. In the second tier, you can go for intact PTH, 25 hydroxy vitamin D. Another thing I don't want to miss in clinical practice in this age group is multiple myeloma. In the appropriate clinical setting, go for extensive evaluation for multiple myeloma. And hyperthyroidism in elderly may not always classically manifest with these palpitations, tremors. You know that there is something called as apathetic thyrotoxicosis. A subset of these patients can also present as fractures. So it's always wise to get a thyroid function test in a patient who is presenting with osteoporosis. Now coming to the treatment aspects, the basic things which you are all familiar with, a calcium of at least 1,200 milligram per day requirement is there, vitamin D of at least 2,000 international units per day, avoid alcohol, tobacco, exercise, good nutrition, fall prevention. And after all this, we have to consider the pharmacotherapy. Now, this is a very simplified algorithm for the treatment of osteoporosis. The first thing is there a fragility fracture? If there is a fragility fracture, go for treatment for osteoporosis. Now, if you are able to measure the bone mineral density and the T-score is less than minus 2.5, then again you can go for treatment for osteoporosis. If the T-score is between minus 1 to minus 2.5 and the FRAX score is above the threshold, again you can go for treatment options. Now you have a wide variety of FDA-approved options for the treatment for osteoporosis, but basically we divide these drugs as anti-resorptives and anabolics. Now you have two classes of anti-resorptives, that the bisphosphonates and the RANG ligand inhibitor, that is the denosumab, and among the anabolics, the most preferred agent is teriparatide. Now bisphosphonates, you have two options, oral bisphosphonates as well as IV bisphosphonates. Now if you ask me what to choose, is it the oral or the IV bisphosphonates, the data is always stronger with the IV bisphosphonates because even a single dose of zoledronic acid can stay up in your bones till 3 to 5 years. So you give zoledronic acid as 4 mg infusion in 100 ml over 1 hour for 3 consecutive years, and after 3 years you give something called as the drug holiday, where you are not giving any drugs for the next 1 or 2 years. You will reassess the patient. If there is a worsening of bone mineral density or there is a fracture in between, again you can extend the treatment for 6 years. Now you have a very strong efficacy data for zoledronic acid, the Horizon trial, which has shown that the vertebral risk reduction occurs by around 70% at 3 years compared to placebo. Now when you are planning to give bisphosphonates for this patient, just keep these things in mind. It is contraindicated when your eGFR is less than 35 ml per minute. This oral bisphosphonates has this issue of erosive esophagitis, so the patient should remain at least 30 minutes upright after administration of tablets. The issue with IV bisphosphonates, what we see in clinical practice, is a flu-like reaction which can be really troublesome in the elderly population. So generally we give paracetamol 1 hour prior to infusion of zoledronic acid and continue it for at least 2 days. There is a rare risk of osteonecrosis of jaw with bisphosphonates, so it's always wise to get a dental clearance before giving the patient bisphosphonates. Atypical femur fracture is a very rare theoretical complication. Denosumab, as you know, is a potent inhibitor of the RANG ligand. The dose is 60 milligrams subcutaneous every 6 months. You can continue it beyond 5 years, 10 years. But the thing is, do not miss doses of denosumab because there is something called as rebound osteoporosis. So if you miss doses of denosumab, there is a risk of rebound osteoporosis. So start denosumab for patients who know that they are going to come back to you in the next 6 months. So the adverse reactions, we have seen dangerous levels of hypocalcemia in patients who are with chronic kidney disease and who are vitamin D deficient. Atypical femur fracture, osteonecrosis of jaw, again are very rare theoretical complication. Again, you have a very strong efficacy data with the FREEDOM trial, which has shown a 68% reduction in the vertebral fracture and a 40% reduction in the hip fracture. So when do you give anabolics? When do you choose teriparatide for a patient? You give teriparatide when you have a high risk patient. That is, there is a vertebral fracture, the T-score is less than -3. It is given for 2 years. Why 2 years? Because there was some concern with teriparatide that it induces osteosarcoma of bones in animal studies, but it was never replicated in human studies. So the FDA has recently removed this 2-year cutoff. You can continue beyond 2 years. The dose 20 micrograms subcutaneously daily, contraindicated in active malignancy. If the risk here is hypercalcemia, so it's better to do a serum calcium 10 days after starting teriparatide. Now, what to choose, when to choose, this is very clear from the ISBMR. If you are having a vertebral fracture, the highest efficacy data is for teriparatide, go for teriparatide. Now, if you are having a hip fracture, you can choose between IV zoledronic acid or denosumab, depending on the patient's preference or the cost factors. Now, by cost factors, I mean that zoledronic acid is a relatively cheaper drug, costing around 1,000 to 2,000. Denosumab, which was previously a costly drug for around 18,000 per dose, but now has considerably reduced to 4,000. So you can choose depending on the patient's preference. I cannot complete this talk without mentioning the fall prevention measures, because whatever efforts you take for pharmacotherapy, if you are not advising fall prevention measures, then your efforts won't become fruitful. Avoid walking on slippery floors, use handrails while walking. The bathrooms, which are the notorious area for most of the fractures, should be well lit, and you have to install grab bars whenever possible in the bathroom. So this would be my take-home points from this talk. Osteoporosis is very, very, very common and often undiagnosed. Every fragility fracture is a red flag sign. Do not always rely on the bone mineral density parameters. Think of fracture, fracs, TBS, which I have just brushed through. I again want to remind you that therapy actually works. We are seeing good results with more than 100 patients on this anti-resorptives and anabolics, and they are doing fine. So consider anti-resorptives or anabolics in the appropriate clinical setting, and fall prevention is actually fracture prevention. Each patient is different. You have to individualize the treatment options. So let's all diagnose and treat osteoporosis. Let's not make our elderly geriatric populations last years bent and broken. Let's help them to be more upright and independent. Thank you.
Thank you, Dr. Ashwin, for an excellent talk. I think he beautifully covered all the topics in the osteoporosis. Started with the fragility fracture, the significance of DEXA scan, and how irresponsible use of proton pump inhibitors can lead to osteoporosis and the management aspect. Due to short of time, we'll permit one question. If anybody has got a question, you can ask.
Before the person can ask question, I hope everybody knew why he got first rank in entrance examination and why he got so much of gold medals. I think he never saw anything. It was, I think, one of the best talk I have heard in recent past. Thank you. Keep it up.
Bisphosphonates can be given as for prevention strategies if the patient, especially if the patient is on chronic glucocorticoid therapy. Now, if the patient is on chronic glucocorticoid therapy, if you are planning to continue glucocorticoid at a dose more than 5 milligram for more than 3 months, then definitely there is an increased risk of osteoporosis. In such patients where you will plan to continue for steroids, you can give bisphosphonates yearly, and you can reassess the patient based on the bone mineral density parameters. And any chronic systemic disease where you think that it is going to affect the bone mineral density, you can prophylactically give bisphosphonates.
I have got a question for you. See, so you said about this calcium supplementation. So what sort of calcium is to be given? Secondly, cardiologists nowadays, they doesn't want to give high amount of calcium because of calcium score. And what's your...
Very valid question, madam. In fact, I'll add one more question to that. The patients will ask, if I take calcium supplementation, will I have a myocardial infarction? If I take calcium supplementation, will I have a renal calculi? So the studies are very clear regarding this. The requirement of calcium in the postmenopausal age group is 1,200 milligram. That means from the diet and the tablets. Now in the Indian diet, considering the Indian diet, if you take 1,000 milligram of calcium from diet, the mean absorption is 429 milligram. That is because of the high presence of phytates and oxalates. So invariably you will need supplementation in the postmenopausal age group. Supplementation, you have two forms of tablet, the calcium carbonate and the calcium citrate malate. The calcium carbonate has an elemental calcium of around 40%, so you can give just a 500 milligram milligram tablet. If you are giving calcium citrate maleate in patients who have achlorhydria or who is on proton pump inhibitors or any other issues with the GI, then you can give citrate maleate at a dose of, that has an elemental calcium of 20%, so you have to give twice the dose. So vitamin D, at least 2000 international units per day. Now regarding whether it will cause vascular calcification, the studies which have shown that this vascular calcification, the mean dose of calcium was more than 2100 milligram. So in the dose where we take 1200 milligram, it has never produced calcification, it is generally safe. And the risk factor for renal calculi is calcium deficiency and not calcium excess. Thank you.
Thank you, Dr. Ashwin Valliyot. I think he needs a big round of applause. Thank you.
Thank you, Dr. Ashwin, sir, for that wonderful presentation.